Hi, everyone, and welcome to the next edition of the Clivity Academy. Today, we're going to jump into coordinated care and value-based care arrangements. And care coordination is a pretty interesting animal when you start thinking about how, if you reflect on all of the things we've done in the Academy, how you might need to understand the parts that are in play, how you might need to understand how reimbursement works for alternative payments, how you might need to the concepts of data and technology and how the contracts work for incentivizing behaviors. Really, all of those start to play a role in coordinating care. Usually these are engagement models of care that happen in between encounters at the point of care. And so we'll often think about taking the kind of data, filtering it through a technology lens to create segments or cohorts, and then managing those segments to get good outcomes. That's sort of the simplest picture. Again, sort of taking a randomized part of your population that are identified as part of a cohort where they may have high risk or they may be overutilizers of certain services. They may have complex medication management requirements, and then figuring out how to address those needs, typically through assessment, and then landing on actionable insights that drive patient management, often in between visits. So that's what we think about when we typically teach about coordinated care. In care coordination, you really have to follow a playbook. And so we'll use a complex care management example and think about these in terms of workflow, right? So in every workflow you might have in a traditional model of care, it's episodic. So whether it's an acute visit or it's a point of care primary care visit, or if it's a specialty consult, there's often a very sort of routine pattern that follows those patient journeys. This is very similar. So this is the routine you'd expect to sort of see. How when we're thinking about populations, do we identify cases? How do we enroll them in certain programmatic engagement processes? How do we assess their initial journey, how they enter that model? How do we assess them throughout the journey itself within the model? What affirms or evolves a care plan, and then how do we ensure that we're following up and monitoring progress? And then, if possible, how do we get them promoted back out of that program once we've removed barriers or provided the right kinds of intervention to change behaviors? So that's the concepts we typically contemplate when we're doing work around care coordination. So let's talk about them individually. So case management or care coordination really often thinks about identification as the first step. So you can't target or engage patient populations across the whole because you just don't have enough resources to spread, your clinical team like peanut butter across all patients. So you have to first identify who are your rising risk or high risk patient populations. So these are examples that you'll see here bulleted out that are often, the kinds of things you might want to think about as you build your case identification strategies. Once you've identified the population, you want to recognize that initial cohort that you've identified really have to have, they're candidates, right? They're candidates for potential inclusion in a program. Once you call or make outreach to those candidates, you then have to enroll them into the program that's appropriate for them. So if we're using complex care management, this would be a person that's on the rising risk journey. They're nearer the top of the acuity pyramid, so they're chronically complex. And often you're wanting to ensure that we do more routine care and supportive care in between encounters. So this is the enrollment stage. You want to land that particular patient into care managers' queues so that those individual care managers, who are often CNAs, medical assistants, RNs, LPNs, occasionally will play those roles, but those persons will sit in between encounters and largely start to work on assessing the patients. So when they do the initial, this is a seriously ill management population prototype here that is used with some of our particular customers in care coordination. This is them looking at how this particular person is doing when they first enter the program for the seriously ill patient population. And what we have the ability to do is see all of the things that were created throughout time to get this person from the candidate to the enrolled patient cohort. And then once they're in that cohort, you need to be able to assess the patient's needs. So inside of this, you may see examples of if this person's managing highly complex cancer that's often fatal, or so that diagnosis is metastatic and there will be a short prognosis. There's some specific assessments you might want to do related to the person's feelings about this prognosis or diagnoses. You can do PHQ-9s, PHQ-4s. You can do assessments that are related to the kinds of things that you would expect to build in a care plan. Care plan is the next item on the again the workflow. So targeting the patients, identifying those that are candidates for enrollment, enrolling the patient, and then starting to build assessment and care management care plans are important. So you have to be able to take in detail. Ideally, your care plans are supported by clinical decision support. So if you started to see this person who's chronically complex starting to have other symptoms where maybe the functional status of this patient cognitively is dropping, you want to capture Karnofsky or FAST scale. Those should be alerts based upon what you see in your care plans that you build. You should be able to also think of the unit for a patient that's this sick, not as just the patient, but the patient is a part of that unit. The family caregiver, often in the United States, we call that daughter care, needs to be supporting this person through the last corridor of life if it's that complex. And then obviously you need to also support that proxy, especially if it's a healthcare proxy, with the ability for them to actually provide insights about this person who's potentially first burdened with physical medicine problems, now mental health and dementia-related problems from a cognitive functional status. Now you're engaging as much as or more with even the daughter, if that's daughter care that's happening here. So these are examples of the kinds of things that you'd want to investigate as you build out your care coordination. As always, we're interested in your feedback. We're interested in any things you'd like for us to bring as content, and looking forward to seeing you on another episode of the Academy soon. Send us your information at info@Acclivity Health for further help on this particular topic or other topics you'd like for us to bring to life. Take care.